I am in a discussion with a vendor that provides integration services for healthcare providers. If the client they are serving has an EHR that does not directly support data exchange with their local health information exchange, that is an HIE, how would they help their client meet the requirements of the MIPS Promoting Interoperability PI HIE measure?
Oh, great question, James. You're making me work on this one. First, a quick review. Promoting interoperability is one of four performance categories in the merit-based incentive payment system, or MIPS. The other three performance categories are quality, costs, and practice improvement activities. Now, all providers who are subject to MIPS are subject to all four performance categories unless they qualify for a specific exception for any one or multiple of the categories. Now, starting with a 2025 performance year, all advanced payment model participants will also be subject to the promoting interoperability or PI performance category. They will be subject to promoting interoperability in all cases, including if they are participating in a MIPS APM or a qualified participant QP, or partially qualified participant, that is a partial QP, in an advanced APM. Now, the requirement for PI lists 4 objectives, although you should consider it to be 5, and I'll explain that in a moment. The first objective is electronic prescribing. The second is health information exchange. The third is provider to patient exchange, that is giving patients access to their data. The fourth is public health and clinical data exchange. For instance, sending data to your state Center for Disease Control, that is disease reporting, or sending data to your local immunization registry. And though it's not listed as an objective, there are several other requirements that can be lumped together under the heading of infrastructure. And infrastructure includes several required actions and attestations concerning the technical environment and its security. Now, the question you've asked is about the second objective, the health information exchange objective. More specifically, the question is about the second of 3 options providers have for satisfying the HIE objective. To satisfy the HIE objective in promoting interoperability, a provider must achieve any of these options. First, you support electronic referral loops. There's 2 elements to that. You have to achieve both or qualify for one or the other exclusion. And that is, you electronically send health information in support of a patient referral or transfer, and you electronically receive and reconcile health information when accepting a patient referral or transfer. So now the exceptions are if you don't make referrals or don't refer patients at least 100 times during the whatever your reporting period is, be it previously 90 days, now going up to 180 days. You don't need to do this. You have an exception from this. And if you don't accept patients in referral or transfer at least 100 times during the period, you get an exception from that. Now, your next option is bidirectional exchange with a health information organization. That is your HIE, typically. And it means that you need to send them information and receive the information from them about your patients. So that's the second way of dealing with this measure. And the third is to enable exchange under TEFCA. TEFCA is that's TEFCA, it's Trusted Exchange Framework and Common Agreement. It's a specific national infrastructure for bidirectional HIE. It's got a national scope, not a local, regional, or state approach. So any of those 3 ways can support the HIE objective. Now, the ultimate vision behind this measure is that every EHR come with functionality that can be enabled using an administrative tool, inputting the network address of your HIE, of your health information exchange, or whoever else you're exchanging data with, and designating what information you want to push or send and what information you want to pool or receive. It should be no harder than enabling your email address and your email server in your email client. So think of it in those terms. Now, if your EHR does not come with that functionality, or if it does come but is not adequate for your needs. You have other options that fall generally under 3 categories: buy it, build it, or engage it. To explain, if you're going to buy it, you'll buy a product off the shelf that'll do it. An interface engine is the likely option. You install it, you configure it, you run it. It will operate between the EHR and the HIE, the Health Information Exchange technical environments. You could build it. A skilled software engineer or database engineer should be able to accomplish the same using any of several coding tools or database tools available to them. It will also operate between the practice electronic health record and the HIE technical environments. And third option is to engage a vendor. The vendor will buy it or build it. They will either set it up in the practice environment to connect the practice directly to the HIE, or they will be an intermediary with three-way connection, receiving and sending data to the practice, and receiving and sending data to the HIE. Now, to get credit for any of those, it has to be operational for at least 180 days in the performance year. Now, the final hurdle to any of these is certification. If it is installed and running, it's not going to count unless it is certified. Somebody has to certify it. It can be the practice, it can be the health system, it can be the HIE, it can be the third-party vendor, it can be the creator of the process who's, well, I guess they become a third-party vendor in that sense. But even if it works, if it's not certified, it doesn't count. Now, certification doesn't need to be a barrier to getting this operational. If your HIE connection works, certification should be achievable. Certification is going to show that you understand the requirements of the data exchange and that your tool works. It's going to show both. It doesn't matter if you've built it or bought it. You'll still need to show that you can make it work with a sample data set. Now, neither certification nor cost of certification is trivial, but the cost isn't astronomical, and the effort is more tedious than it is difficult for someone who knows what they're doing in these areas. Now, the resources for all of your certification questions is www.healthit.gov. That's a site maintained and containing data about ONC the Office of the National Coordinator requirements for Health IT. Choose a certification of Health IT topic. You'll find a list of the vendors that are approved to certify your process, specification and guidance documents, and legislation and rules underpinning all of it. Now, to get certified, you engage and pay a certification vendor. The vendor will review with you the requirements and your local product functionality. When you agree that you are ready, they will connect remotely and watch you run a test data set through your system. When you get it right, you will be certified. You'll be listed on the healthit.gov website. You'll enter a maintenance of certification program, typically with a vendor that got you certified, that involves an annual fee and less stringent periodic attestation requirements. You will typically not be subject to a direct observation again, unless or until you significantly alter your system or the certification requirements significantly change. Now, any of the involved parties can be the certified party. The EHR can get it certified. The practice or health system can get it certified. The HIE can get it certified, or the third-party vendor can get it certified. In this case, the one you describe here, it makes sense to me for a vendor that is setting up HIE connections for multiple healthcare practices and EHRs, that you provide the functionality and obtain the certification to benefit all of the providers, practices, EHRs, and HIEs you serve. But again, in this case, there's a lot of different ways to skin the cat. So thanks for a challenging question.